I am Garrison. I work for USAID. I am going to assume people know a little bit about USAID. We're a federal agency that does all the federal government's development work. And I'm the Senior Social Behavior Change Advisor for our Maternal Child Health and Nutrition Office. We do behavior change work. You've probably seen a lot of it in the field. Some of it good, some of it less good. And we have struggled for years with many confounding factors, some of which you even heard today with some of the presentations. USAID is probably one of the largest investors in behavior change. So behavior change incorporating lots of behavioral sciences, but traditionally focused mostly on communication, using marketing techniques and working on changing social norms and that sort of thing, things you're probably quite familiar with. So one of the things that people have asked me is how are we beginning to incorporate some of the approaches from behavioral economics, behavioral sciences, behavioral insights, I hear all these terms, into our large-scale social and behavior change work. So that's what I'm talking about. And please feel free to stop me at any point to ask questions. So these 35 years of investing in these large-scale behavior change projects around the world have sometimes led to great outcomes and sometimes not led to great outcomes. But the thing we've really lacked is evidence. Evidence about what worked and why it worked. Evidence about what could have been changed in the approach that would have made it better. And so the USAID as a whole agency has really committed to new innovations and rigor around behavioral sciences and the evidence that we, excuse me, I have a little bit of a cold, the evidence we generate and the way we report that evidence. For the behavioral side of things, a few years ago, we were challenged to defend how investing in this field is really valuable to the global health outcomes that we're aiming for. And so we had a large evidence summit. I'm giving you a little bit of history before I dive into what you want to know. And the evidence summit, you can read the results of it. It was a little painful. We were looking for peer-reviewed evidence on what has worked in population-level behavior change. That really highlighted how poorly we had been documenting the 35 years of work. And not just documenting, not in terms of methods, even how we report on it. So there currently is a WHO-led collaboration with all these people, all these different groups, on guidance. So it would be official policy guidance on both the methodology and what counts as evidence in the behavioral area and how you report on it. And that's in process now, and anybody that's worked with WHO on developing guidelines knows this is a very long process, and it's a very rigorous process, but it's moving very quickly forward, and there's a lot of buy-in. So we think that will sort of send the signal that we're no longer interested in continuing to base our intervention choices on poor evidence. So I'm not going to spend time there, but I want to jump right into some of this question of how we are incorporating these new approaches into the work we do. Because we have to work on a huge scale. So we have to think about scalability all the time. How many of you know there is a White House Social and Behavior Sciences team? So there is. President Obama put an executive order forward about a year and a half, 2 years ago, I guess, 2014 maybe, to help federal agencies tackle the challenges that they're dealing with. And it's a primarily domestically focused. and to apply behavioral insights and rigorous evidence to federal programs. USAID wasn't really part of that, I don't think, that design, but we decided to jump in. So with this team, we can access academics and we can infuse their knowledge into our existing projects. So you heard from Maggie. Maggie's one of our PIs on one of our projects, and Nick is working with the sbst. So we're trying to find ways to bring groups like this into the fold of the work we do. It's also been interesting because it's allowed us to work through our traditional partners to expose them to things that are happening outside traditional health communication expertise. So you can go look at the executive order if that stuff gets you excited. But we have had some challenges. Data. For those of you that work in various countries, you know, data is a challenge. And if our whole goal here is to bring forth evidence, we need data. And we don't have the budgets to develop whole new data systems. And we need to use existing data systems. And in fact, when you look at some of the work that sbst is doing domestically, you see the value of strong systems level data to be able to demonstrate effective interventions. And we don't have that most of the time. And then this question of scale. So we have, I think, been very challenged in incorporating some of these new ideas from the behavioral economics or behavioral sciences field at the scale that we're looking for. But we're working through it. So I'm going to give some little examples. I'm not presenting big designs and I'm not presenting big statistical stuff. I'm just presenting blurbs of things we're doing so you can understand how this is getting used. And then I'm hoping that you will be interested enough to check out what we're doing and come play with us. So in Mozambique, we had an SMS intervention with HIV patients that were sent text reminders to take their medicine and go to appointments. This is happening quite a bit. I mean, we are using technology to improve the way we do our work. But a lot of times we're not testing it in rigorous RCT level designs. We had very, very strong results in this study. After 12 months, the patients were more likely to stay on treatment. We decided to extend that study by 24 months. And at the 24 months, the effect died down. So that's an interesting thing for us to know in the future, that we're going to have an initial quick effect, but it's not going to be a long-term effect. This study is still continuing, but that kind of lesson gets built into the next time, and the next time we do it better, and the next time we do it better. That was our sort of first foray into really trying to do short, and I should emphasize that. We're talking about short RCTs. We're not talking about 10 years. And when we say randomized control trial in the federal government, it makes people really nervous because they see big budgets and they see big timelines and they say we don't have time. We're looking for ways to do rigorous, but not costly testing of our interventions. So this year with the sbst, they decided to figure out how can we get more people involved in this? How can we work with USAID missions and get more people incorporating these ideas into their work? So they came up with this brilliant idea to do a design sprint. And I went with them on this journey. And they screened 100 eligible participants. So what we asked is our USAID offices in countries to identify a problem that they'd been dealing with, something that seemed and present it to us. They had to also demonstrate that there was data available, that we had a partner that was interested in working with us. So they screened these 100 eligible partners, and in the very end, they had 4 country teams come together. So it was pretty rigorous, and I will say that not even all 4 of those countries are continuing. So we're really learning about how difficult this can be. So we all came together for 2.5 days. And we brought nobody in this room, but we had a number of academics that came to South Africa, sat with these teams, looked at what they had, and tried to put together designs of interventions and RCTs to test those interventions. So we have, I'm just going to present a couple of these. One is in Ethiopia, HIV medication adherence. So our goal is to increase the HIV medication adherence in Ethiopia. And while the national HIV prevalence rate in Ethiopia is only 1.2%, among female sex workers, it's quite high. So when I say USAID Ethiopia, this includes the SBST, because we consider ourselves one big federal government. So not to confuse people, this is including our SBST colleagues, is working with our partner PSI, and we actually have some PSI people in the room today. And they're looking at some of the structural and behavioral barriers that exist around HIV care. All we're looking at is the impact of encouragement on doctors' appointments. So I want to say a little bit about how this came about, because the excitement around this was tremendous, even among our USAID colleagues in Ethiopia and among our PSI colleagues. And initially, this design, I thought about putting it up here, but then I thought it'd be way too much to talk about. But it had so many arms that were exciting to test. But when you really overlaid this idea of feasibility, what if you proved that this really complex part arm actually worked, but there's no way anybody's going to pay to scale that up? Do you really continue with that arm of the study? That becomes like fun to know research, something that is fun to present in a panel, but it's not really going to make a difference because we know no one's going to pay for it. So there was an arm of the study that was really exciting to everyone, lots of interesting technology, but in the end we said, no one's ever going to pay for that if it works. So we stuck with something quite simple. And so here it is. Just encouragement text messages, praise and acknowledgement messages post-appointment, and then the business as usual. Now, I can't give you any results. You're going to have to check back because these are all just starting. In Nigeria, we're looking at malaria prevention. So we have an issue with malaria around intermittent preventive therapy, something you're supposed to take when you're going to your antenatal care visits. But in Nigeria, only 19% of women received the recommended 3 doses, which is actually, I think, going up in the next set of recommendations. Anyway, so USAID, that would be the SBST, Johns Hopkins University, and Swarthmore are working together to change the referral forms. If I showed you the referral forms before, they were just what you see in your own doctor's office, probably a piece of paper that said, go to your doctor at this date. So they're trying to use some of the things around emotion to lead a woman to understand the health of her pregnancy. This got, the original card was fetuses, and it didn't go over so well, so the pregnant woman has seems to be testing a little more positively. So the idea is to measure the impact of these new cards. Will this trigger a woman to seek antenatal care, first of all? So that's a challenge, right? A lot of people don't even know they're pregnant until they're way into their pregnancy, so we have a challenge there. So there's a whole issue around when you actually know you're pregnant. And then typically women only get 1 to 2 antenatal care visits. So will it also affect antenatal care? And then this last one, Maggie, is helping, right? This is the one you're helping on, right? She's our PI on this. Is to increase the number of women who come to postnatal immunization appointments and take up a family planning method. This is partnering through our traditional partners, and I think what I'm trying to emphasize here is that these partners that are working, these traditional partners that we've worked with, they're used to working at this scale, but they can always use new ideas. So how we partner, how we pair is really essential to diffusing the things you're learning into the larger scientific field of health and development. So we're trying to leverage a moment when many women in need of family planning methods are already in the clinics. And so the idea is to test the impact of training providers to offer family planning services in a slightly different way. So of course they offer family planning services. But if you saw the current way they're offering family planning services, they're just offering family planning services. They have some information they give the woman. What happens when you start adding in ways to simplify the information, ways to explain the family planning methods by effectiveness, or by targeting what the woman wants, what the woman's needs are by the family planning method that would be most appropriate. You have to, in the federal government, provide information on all family planning methods. But you can organize those family planning methods in whatever way seems most reasonable. So how do we incorporate the ideas that we're learning in the behavioral sciences into that kind of information? So Mindy Hernandez, who's not here, put these slides together. But so just what I was saying, we're trying to address some of these psychological issues at different points. So going to the clinic, there's a hassle involved in that. How do you minimize that? There's provider bias. It takes a little longer to counsel about certain methods than others. There's also cultural biases that providers bring to the table. So how do you address that? And then how do you address the social norms around the bias in the family or community? So right now, this is the intervention design. It could possibly have already changed because in all of these cases, we've had to make a lot of adjustments as we learn more, as we see what data is available, as we understand time constraints, sampling constraints. It's been very interesting, and we are trying to document all these lessons learned so that everyone benefits from these efforts. I won't read all of those, but you see there. So I didn't want to spend a lot of time here. I think what we were trying to get across to you is the work you're doing is super valuable to a lot of people out there, and we need to figure out strategically how to embed this work into the larger work we're doing and how to do it at scale. So if you want to learn more about the SBST, Lindy wanted me to point you to the newest annual report. It also gives you the full breadth of the work they're doing domestically. And just a little shout out, I think they put a call out, and maybe Maggie or Nick or somebody knows this, they put a call out to academics once a year. And I think that's coming in October. So you might check in a month or in a couple weeks to see if you're interested in possibly being involved. Thanks. Any questions? What we're doing, even within our own team of behavior change advisors in USAID, is we are trying to figure out a strategy for, I guess it'd be like a checklist, but of a list of types of data we need on a regular basis to track behavior change. We don't have that. Almost anything you see out there in the literature around behavior is something we created just for that project, which seems so inefficient. And yet, that's how it's been done. The advantage, we're at this, I think, excellent point in time where countries are building much stronger HMIS systems. They have started really taking on with great excitement DHIS2, which I don't know how many of you know it, but it's quite flexible. And then we have our ongoing demographic and health surveys, and we're looking across all of those to see what could we build into those that would give us yearly, annual, whatever, ongoing data. I manage a project that's looking intensively at that, but I think having a collective effort, in fact, I'm writing a proposal right now with just trying to figure out where it goes, or people keep saying, make it a Bellagio meeting. I was like, oh, that seems a little bit. Around data and who can we bring to the table that can help us with this? Because it is the number one barrier to being able to rigorously test what we do in a low-cost way. I should also say that we are making an intensive effort, not that this is that interesting to you, but I think it might have a large long-term outcome, to really change the way we design and program behavior change work. So that's not going to be an immediate thing you're going to see, but I keep saying I'm done with this field if by the end of my job now I have not changed some of the designs that I see happening, where the expectation is absolutely there's just no way there's going to be any success in behavior change. Just by virtue of the way it is designed, and that partner has said, the partner is held to that. So it's not like they can say, ha, you're full of baloney, we're going to do it this way. That's not how federal funding works. So it has to happen way back in the design and thinking stage. Nick. Right, so I think there's lots of these pieces of data that if we had the people in the room there is a lot of thinking and funding going into improving on-the-ground data systems. So why not take advantage of that to make sure the clinicians they're getting all their stuff in there, but the behavioral science field is absent in the discussions. So we have lots of examples of where we have sort of an overarching intervention that gets adapted at community levels. What we don't have is a way to test and measure that. So it becomes, it kind of worked here, so we have to adapt it here and here and here. And we have talked about this very thing, that we think there are new statistical methods that could help us design from the beginning ways to track and measure those different models that are happening at community level. I mean, we have to adapt it at community level. There's some things you can change, right? You can make an opt-out option for something, or a default option that maybe affects the whole population. But on something like breastfeeding as a behavior, that has to get quite specific in terms of who your target population is, and there's not going to be an intervention that's going to address an entire country of women. So I don't have a place to point you. I have an answer that that there is a lot of adaptation that happens, but there's not a way we're measuring that adaptive strategy on an ongoing basis. It just sort of is happening, and we're hoping it works. I don't know how, sounds terrible, but that's just the truth. Any other questions? Yeah. So yes and no. There are just restrictions there's just rules. It's around competition, or transparency, that it's your taxpayer dollars, and there are rules that go with those taxpayer dollars. That said, I think the more we ask questions about, we want to do this, find us a way to do this, we find people in the federal government, they are rare, but they know how to find the loopholes and how to help us navigate. And so I think part of it is we didn't know what questions to ask. Like we didn't know what we wanted or what we needed, and now we're realizing, wow, we really wish we had the ability to do X. And it's pretty amazing when you really understand the rules. Well, as we all know, when you really understand the rules, you understand how to make the rules work for you. So funding isn't changing, but I think our understanding of some of the flexibility around that funding and how it could be used is getting more sophisticated.